There we go. So I'm so thrilled to introduce Dr. Suzanne George. She is a doctor at Dana-Farber Cancer Institute. She's the director of clinical research there in the sarcoma program, and she's an associate professor of medicine at Harvard Medical School. I met Dr. George in 2014 or 13 when she was a speaker at our very first LMSDR conference. So thank you, Dr. George. It's been a long time.
Yes, Sharon, thank you so much for inviting me, and thank you everybody for coming. I actually think of that conference often. It was great. It was in Colorado, and I had never really been at altitude, and I thought, I don't usually get nervous for talks. Why is my heart racing? And I think it was just because I wasn't used to having not enough oxygen.
And it was your anniversary. You came all the way out on your anniversary.
It was our anniversary. Yes, my husband actually came too. So it was fun. It was really nice.
Well, our next conference is in London in a couple weeks. So.
Oh, that's great too.
Yeah, we're excited.
Plenty of oxygen.
I'll let you present.
Thank you. All right. So I'm going to take a minute to share. I'm going to share my screen. I actually have a relatively brief presentation. And I'm just going to go through some slides around the role of estrogen suppression in leiomyosarcoma of the uterus. Oops, sorry, there we go. I picked some papers to talk about and just wanted to then open it up for discussion. So leiomyosarcoma of the uterus and the role of estrogen suppression is actually something I've been interested in since pretty early on in my own career. As Sharon mentioned, I've been at Dana-Farber for a good long time now, and I just always wondered, like, why is it that, is there a role? Like, does the estrogen expression that's present on uterine leiomyosarcoma cells, does that tell us anything about the tumor biologically? And if it does, could we use suppression of estrogen as a method to try to treat the disease? What I also observed very early on is that people's tumors behave differently. Some people's tumors behave very aggressively, and other people have tumors that would behave very quietly. And this paper does not summarize that, but around this time, this was a paper that we published in 2013. This was actually the first experience of prospectively evaluating estrogen suppression in women with metastatic uterine leiomyosarcoma. Up until this time, most of what was in the literature were single center reports. A center, and I'll show you actually some from our own center, but experiences that individual clinicians had in patients that had seemed to do particularly well on estrogen suppression. Many of them had high expression of estrogen and progesterone receptors on the tumor, but were also being treated, again, with the suppression of estrogen, often through an aromatase inhibitor. What was hard about the interpretation of those data were that it was hard to know whether the generally good outcomes that were being seen, so slow growth, slow change in tumor, whether that actually was specifically related to the drug, meaning the suppression of estrogen, or whether the estrogen and progesterone receptor itself was just a marker of better behaved tumor. So what we decided that we wanted to do, and at that time, there was some literature, again, that's kind of suggested, well, maybe just having estrogen and progesterone expression on the tumor in and of itself was a reflection of more favorable tumor behavior. So what we did was we said, okay, well, what would happen if we studied this in a more traditional clinical trial setting? So we prospectively enrolled 26 women that had some degree of estrogen and or progesterone receptor expression on their tumors. At the time when we started this trial, which was probably, I don't know, around 2009 or so, we didn't really know, like, what did it mean to be ER positive or PR positive? What defined that? So meeting with our GYN pathologist, Marisa Nucci, we just made a decision that if there was any expression at all, like anything even above 1%, that we would consider that positive. And so what we did was we enrolled 26 women. The average age was 56. Most patients had a performance status of 0, which means that they were pretty asymptomatic from their tumor, although about 30% of women had some degree of symptoms. At the time of diagnosis of uterine leiomyosarcoma, most women in this series happened to be postmenopausal, and most people on average had had at least 2 prior types of chemotherapy. When we looked at the tumor characteristics, what we saw was that most women, the tumor for most women expressed both ER, meaning estrogen receptor, as well as PR, progesterone receptor. And when looking more specifically at the degree of staining, about half the cases had more than 50% of the tumor cells expressing the estrogen receptor protein, and about 50% had less than, and about half, around a third had greater than 50% tumor cell expression, and around a third had less than 50% tumor cells expression. And then there was a group that were unknown because of difficulties with the technical components. Interestingly, the PR staining was similar. It was pretty similar. So, and when I talk in this case, in this context about ER and PR expression, what I mean is protein expression on the cells. It's not genomics, it's not genetics. It's just, is there the protein on the cell? And that's determined by the pathologists through immunohistochemical staining. Okay, so what did we learn? So what we saw was that on average, this slide over here is a PFS, or progression-free survival curve. And if you looked at all the patients, all 26 patients together, which is a relatively small group from a statistical perspective, by 12 weeks, about 50% of patients had already progressed. So what that was telling us is that in this group where we used a very low threshold for ER and PR positivity, overall as a group, generally the tumors were continuing to grow within 3 months, despite suppression of estrogen by using an aromatase inhibitor. If, however, we looked specifically at the patients who seemed to do particularly well, so there were 3 women who did particularly well, so that they had were without any progression at 6 months. And we said, okay, well, what was different about them? How were they different? And what we saw actually was that in all 3 cases, including this was year to age at diagnosis, a very young person, on all 3 cases, there was very high expression of both estrogen receptor and progesterone receptor. So almost every single tumor cell had ER and PR present. The other thing that was interesting that we noted at the time, because again, as I mentioned earlier, there was a literature that said, well, estrogen and progesterone receptor retention, like the ability of these cells to hold on, the ability of these cells to continue to make these proteins, was a reflection of favorable biology. That was I think that is true, and that was very much in the literature. But what we wanted to see was, well, gee, did that mean that they had a low mitotic rate? Well, for one case they did, but for the other 2 cases they didn't. They had a very high mitotic rate. So mitotic rate alone was not a predictor of potential benefit from this approach. The other thing, and the last thing that we looked at, was we said, okay, well, maybe these were just well-behaved tumors to begin with, and that they weren't really growing and changing, and maybe estrogen didn't really have anything to do with it. The estrogen suppression, maybe it was just that these were slow changing tumors, and in 6 months they wouldn't have changed anyways. So in order to try to assess that, we looked at what was the disease pattern and behavior prior to enrollment. And what we saw was that for at least 2 of them, 2 of the 3 cases, patients had disease progression at the time that they were entering, and that progression happened over a 3-month period. Again, suggesting that at least for these 2 cases, the introduction of the estrogen suppression with the aromatase inhibitor may have likely did change the natural history of the tumor behavior. So this, I think, was the first study. There's been another study actually from an Australian group, but this was the first study that looked at, again, estrogen suppression, but specifically looking prospectively and looking at the degree of ERPR expression with regard to suppression of estrogen and how they might be related. In follow-up to that, soon thereafter, we actually published a case report of a patient. As you can see here, we entitled it Hormone Dependency in Metastatic Low-Grade Leiomyosarcoma Following a Diagnosis of Uterine Smooth Muscle Tumor of Uncertain Malignant Potential. This tumor type, smooth muscle tumor of uncertain malignant potential, is also known as STUMP. Just by the initials S, it's smooth muscle tumor, uncertain malignant potential, STUMP. And basically, it's a tumor that starts in the uterus, and it is just what it says it is. It's like the pathologists historically haven't been able to discriminate whether it's going to be behind a well-behaved tumor similar to a fibroid and just be removed and never heard from again, or whether it could actually metastasize and present more like a leiomyosarcoma. And that's why it has the term uncertain malignant potential. So this particular patient is a patient of mine, actually still is a patient of mine, who presented with a stump, had a hysterectomy, and had no follow-up and no disease for, oh gosh, it was probably about 8 years. Ultimately, presented to her primary care doctor with pulmonary symptoms, with like a cough, and was found, as you can see in this lower panel, this on chest CT, to actually have significant pulmonary metastases. What you can see in this scan for folks that may not look at scans regularly is this panel A is a CAT scan. If you can see my arrow, this is the spine, this is the sternum, so the breastbone, the ribs are on the side. So we're basically, the level we're at is at the lower part of the lungs. This is the liver. This is the heart. So these are normal structures. This is the aorta. But what isn't normal was this mass here, or these small masses here. The patient's symptoms got better. She did just have a cold, and it was just somewhat fortuitous that these lesions were found. She went ahead and she had a biopsy performed of these, of this lesion, of the pulmonary metastases. And that's what the picture is up top here. This picture is it's a core biopsy from the lung metastases biopsy. And the brown staining is actually of estrogen receptor. So what this is, and on this panel, the PR, the brown staining is progesterone receptor. So nearly all cells universally had high expression of estrogen and progesterone receptor. What was interesting in this case is at the time when the patient presented, she happened to be on hormone replacement therapy. And what we decided was, while we were figuring out what we wanted to do exactly, was we decided to stop that. Like, let's just stop the hormone receptor, the HRT. And before we were getting ready to consider starting chemotherapy or what we were going to do next, we actually decided to go ahead and get a CAT scan, because we wanted to see, some time had passed, like, where's our new baseline? And what we saw was that just with withdrawal of hormone replacement therapy alone, this mass had reduced in size to this mass. And that just further supported this idea, that this concept that in this particular case of the biopsy showing not just high ERPR, which it also showed that it looked like leiomyosarcoma, just by what the withdrawal of the estrogen was telling us that there was a biologic sensitivity here in this case. So then, from a treatment perspective, went on to actually introduce letrozole, which is an aromatase inhibitor, which further reduced the body's level of estrogen. And this panel C was after 2.5 years, and the tumor these smaller lesions had resolved, and this particular lesion had gone down even more. Now, I have to say, this is a dramatic case, and that's part of why we put it out in the literature. But again, it's further supported what we saw in our clinical trial, which is that there was this suggestion of sensitivity to hormonal suppression, meaning estrogen suppression, but particularly in these very, very, very high expressing cells that very much expressed estrogen and progesterone receptor. Now, more recently, and this paper just came out within, Sharon sent it to me, it came out just within the last month or so in Clinical Cancer Research, entitled Low-Grade Uterine Leiomyosarcoma is Highly Sensitive to Hormonal Treatment. This is a retrospective collaborative series that was put together by centers in both Italy and in France. And what they did was they raised this question of really trying. This effort was great. This effort started with actually Roberta Sanfilippo, who's a wonderful colleague from Milan, wanting to work together to understand more about that tumor I mentioned before called STUMP. And so she was gathering cases from across Europe in order to put together a series. And as they were looking at cases with STUMP, what became clear was that there was a subset of women that had STUMP that recurred, therefore was no longer STUMP, was leiomyosarcoma, that had a very particular histology, meaning looked a certain way under the microscope that was very low grade and appeared generally well behaving. So there were 27 women in total that were included in this cohort. Patients presented at different stages. The median age in this cohort was 48. So it was a relatively young population, but the age ranged from 31 to 76. Most patients had asymptomatic. And as you can see, the majority in this series either had metastatic disease, so 59%, or locally relapsed disease at 37%. The majority of patients that develop metastatic disease, the sites of metastases were in the abdomen with almost over 85% of patients with abdominal disease, and then a proportion of those also having peritoneal disease and a smaller proportion with lung disease. Now, these were women that also went on to have treatment with some type of estrogen suppression. And for some women, that was an LHRH analog, which is basically something that you would use to shut down people's ovaries that were working. So this is typically used in premenopausal women with functioning ovaries intact, where you want to suppress the estrogen function from the ovary. You want to shut them off. And then other women had letrozole, which again is an aromatase inhibitor. It stops estrogen production from the non-ovarian sites, but it's only safe to use in people that don't have functional ovaries. Some people use the combination of an LHRH analog plus letrozole, and that would be potentially in a premenopausal woman that you wanted to get further estrogen suppression in. One woman had her ovaries removed, so basically a medical menopause, and in one case, progesterone was used as well, which is not typical. So I think that these cases illustrate, again, dramatic cases of this concept. First, I want to highlight these slides here, the biopsy slides. So what we're seeing, sorry about that. I realized I don't have this well organized, but in this, let's see, where should we go? This here, sort of underneath slide A, which we'll go back to, this is a picture of a biopsy of the tumor. This slide here with all the with all the brown is the estrogen receptor. So again, very high estrogen expressing disease. What you can see here in panel A is actually an MRI. The images have been reconstructed so that the person is standing. This was a uterine leiomyosarcoma that recurred, very large recurrence in the abdomen. This woman received a combination of an LHRH analog together with letrozole. And again, we use that combination if somebody has functioning ovaries So you use the LHRH analog to shut off the ovaries, and then you use letrozole to stop ovarian production in the rest of the cells of the body that might be doing it, like the adrenal glands, fat cells, for example. And as you can see here, it's a little bit hard because I find MRIs tricky to look at, but this was the mass before. It went from one side of the abdomen all the way to the other side of the abdomen. It went from the diaphragm, which is here, all the way down towards the pelvis to this, which you could see being, now it's not even crossing the midline. It's not heading anywhere near the pelvis, which is great. The patient went on to have surgical resection, and you could see a significant pathologic response where what previously would have been these purple cells are the nuclei and the active tumor cells. And here, it's a little bit hard to see on this view because it's not particularly big, but things are much quieter. There's much less activity. The tumor cells had really quieted down. This is figure 2 here is another example from the same paper of a woman who had recurrent low-grade leiomyosarcoma, initially started from stump, but then recurrent low-grade leiomyosarcoma. This is a soft tissue mass here. It's multilobulated in the pelvis, a second mass here. This is at baseline. And after 6 months of ovarian suppression with an LHRH analog, so essentially just shutting off the ovaries, there was significant reduction in the tumor burden. I'm going to this summarize so that we have time to talk and have questions. But just in summary, I think what this literature shows is that selected cases of uterine leiomyosarcoma are sensitive to hormonal suppression. When I say hormonal suppression, I mean more specifically estrogen suppression. I really feel strongly that hormonal suppression sensitivity is related to the degree of expression of estrogen and progesterone on the cells. And it's really the most dramatic responses we see are in people whose tumors are in the greater than 90%. It's just almost a universal presence of estrogen and progesterone receptor. I think lower and mid-range expression is much less likely to respond to this approach. And that's what we saw even in that early paper we did 10 years ago, which is, even at 50%, we really weren't seeing the benefit that we saw at 90%. And testing by estrogen and progesterone receptor is typically done by immunohistochemistry, and that likely is the best way to assess this degree of protein expression. It doesn't have to be fancy. It doesn't have to be genomic based. It doesn't have to be, you don't have to send a tumor off to a special lab. This is done by standard surgical pathology and has been done for years and years and years. This is what's done in breast cancer, for example. So with that, I am going to pause.
Fascinating. And, by the way, Dr. George, we have a few women on here who are responders to aromatase inhibitors. And I can share, I don't mind myself. I was stage 4 and I had 2 lung resections. And I was about 2 years out. And then I was NED and started an aromatase inhibitor, Arimidex. And I haven't had a tumor since, and that's been 19 years. Yeah. And I took Arimidex for 7 years. So that was one of my questions. How long do we know you need to take the aromatase inhibitor? How long it's effective, or how long we should stay on it?
Yeah, no, that's such an important question. And Sharon, I'm so glad that you're doing so well. I mean, and thank you for sharing your story. I think the answer is we don't know the answer. For women that have measurable disease in place, so something that we can see, my recommendation is to stay on, because I think, my concern is if we stop, that what we see will start to grow. And actually, in the case that I meant, that case that we published, we have had some small times where we've needed to take a break, and occasionally the tumor would wake up. So my recommendation for visible disease is to continue with indefinite treatment, especially as long as somebody's tolerating it. I think things become a lot less clear in the scenario that you just described, which is, what do you do for someone that has metastatic disease, has been resected to NED, and then goes on an aromatase inhibitor? How long then? I think we just simply don't know the answer. I think that I think we just don't know the answer. I think it's a very personal decision.
Anybody else want to share their aromatase inhibitor story or have questions?
I have a
Caroline,
question.
jump in. Oh, okay.
On my papers from where I had my surgery and they did the testing, it just says ER positive and PR positive. It doesn't give me a number.
Yeah.
So do I have to go back and request like something else?
Yeah. So at our center, yes, I do. I go back and request, and I say, can you just tell us the degree of expression?
Okay. And they should be able to do that from what the
pathologist should. Yep.
All right. Thank you.
Yep. And if they can't, depending on your individual situation, I have had patients where, for whatever reason, we weren't able to get that information, and then I have had situations where, if it's in the right scenario for that right person, where we have just given a brief course and then done a quick interval scan, just to be sure that if we're not heading in the right direction, that we know early and can change. But they should be able to know just by looking at the slide.
Dr.
Caroline,
George,
you want to share?
I would like to share. I was on letrozole for 12 years and got 12 years of stability out of it. But recently I've seen slight progression. So I've switched to exemestane, and hopefully that I've read that there's a lack of cross resistance, at least in breast cancer. And I hope that may be the case with leiomyosarcoma. But I was a patient of Dr. Morgan's at Dana-Farber. So, and the time that I was seeing him was when your study was going on. I wasn't part of the study, but I followed it.
Yes.
And so I'm a thriver and metastatic at the same time for all these years. But I do appreciate it, and I hope this research continues. And I'd be interested to know if you have any word on fourth generation aromatase inhibitors.
Yeah, no, it's a good question. And thank you for, sharing your information. We miss Dr. Morgan. That's what I would say. I think that the pattern for many of us that treat women with uterine leiomyosarcoma and use estrogen suppression sort of selectively, as we've talked about, is to follow similar to what's done in breast cancer. So, we may go with one class of aromatase inhibitors, and then if that's not working, we might switch to exemestane because it's slightly different in its structure. And then from there, we might switch to something like fulvestrant, which works differently with the estrogen interaction. So I think that I'm not an expert, as many breast cancer doctors are, around estrogen suppression, but in sarcoma, we are always learning from the breast cancer world in terms of different ways to try to take advantage of that potential opportunity for treatment.
Caroline, can I ask, do you know the percentage of estrogen and progesterone receptors you had on your tumor?
I do. It was actually 78% estrogen receptive and 82% progesterone receptive. So high, but not 99 or close.
Yeah. I have to, mine were 99% for both. Yeah. So it was extremely high. Yes.
Yeah. No, I mean, that is a good point, Caroline. I mean, I think the super dramatic responses we see seem to be correlated. I think when you're in the 50% range, my experience hasn't been that we're seeing a lot of benefit, but when you're in that 75, 85% range, I certainly, you're a great example of that being a helpful strategy for you. And certainly, again, similar to what we were talking about with Beth is, if you're going to try it, you just want to make sure that you have, like with any time you're trying a new treatment, you want to make sure it's like the right time for your disease, that you have close interval follow-up. So if it's not the right strategy, you can move to something new. But I thank you for telling us that. That's really helpful.
Let's see, Lynn, were you going to ask?
Yeah, I just wanted to add the importance of when one estrogen blocker stops working to switch, because that was helpful for me also. I did have a stump, was told, don't worry, you're fine, it's nothing. And then just had other symptoms, needed to have surgery for my appendix, and they found that I then had LMS. And so I was started on Arimidex, which is an estrogen blocker. And for several years, I had the tumors removed surgically, and then I didn't have any recurrence. And then I had 2 recurrences 1 year apart. And so we switched from the Arimidex to letrozole. And now it's been 1.5 years and I haven't had anything come back yet. So I think even though it seemed like, the estrogen blocker isn't working anymore, just by switching brands, it's basically the same medication. It's just a different brand. Seems like that was helpful.
Yeah. I know, I think that's important to share. And I think, that's another really important message. We frequently are trying to, because hormone suppression is generally better tolerated and can be quite helpful in certain cases, I think it is important to, you don't want to give up on it too soon. But again, it's important. You don't want to stay on things that aren't helping either, but it's finding that sweet spot, just like you described.
I just have one question. Sorry, it's Robin Watts from Vancouver. I just had a question about, is this all in postmenopausal women when you're using the letrozole, or is it also in premenopausal women?
Yeah, no, that's a good question. So the high expression of ER/PR can happen either premenopausal or postmenopausal women. Letrozole is only indicated if your ovaries are not working. So we only use letrozole if people have non-functioning ovaries. So it's typically considered for postmenopausal women, but in premenopausal women that have their ovaries intact, then it can be used in combination with, we call it Lupron, basically a drug that shuts off your ovaries. So first you have your ovaries shut off either with medication or surgically, and then you could use letrozole on top. And the reason is that if you use letrozole in a setting of functional ovaries, you can actually inadvertently stimulate the ovaries to make extra estrogen.
Okay. Oh, thank you for that. And one other question, tamoxifen versus letrozole.
Yeah. So sorry, go ahead. I'm sorry.
No, it just that there wasn't really a comment. No one actually has commented on tamoxifen, and just my friend who has a tumor with PR and ER positive. I do not know the degree of expression, but that was a good comment about going back and looking at the slide. However, she did do a trial of tamoxifen and really just didn't work like she just had. So I can't comment on the degree of expressivity that was in the slides. However, the tamoxifen didn't work, and I just would like you to comment on your experience with tamoxifen versus letrozole.
Yep. No, that's a good question. So tamoxifen, the difference between tamoxifen and letrozole is that tamoxifen works at the estrogen receptor specifically, like it blocks the receptor, as opposed to letrozole, which works by blocking the production of estrogen in the body. Now, if you go way back in the literature, there are case reports of this exact scenario where people did use tamoxifen. personally, there's tamoxifen is also associated or has been associated or loosely associated with uterine sarcomas. It's actually years ago, they put a black box warning on the tamoxifen label because of that. And because of that, I just don't use it in this setting. And the more I've learned about it, it's a rare complication. Primary uterine endometrial cancer, that is not a rare, that's a complication, a known complication of tamoxifen, but specifically sarcomas were also called out as a complication potentially of tamoxifen. So I just don't use it.
Okay. Thank you for that.
Yeah. It's very rare, but it's my own personal
I
preference.
think we've got some questions in the chat. Can you see the chat,
Oh.
Doctor?
Oh, sorry.
Yes.
Okay. Want me to read it, or did you want to read it?
If a pelvic tumor removed was high, but lung mets are not PR positive, would going on an inhibitor help the pelvic recurrence or help the lung mets as well?
Yeah, it's a really good question. I think that if the lung mets are present, and it really depends on what needs to be treated. So if the lung mets are still in place and they're growing and they need the treatment, personally, I would be concerned that going on an aromatase inhibitor wouldn't be the right fit. Yes, it might help to reduce recurrence because the original tumor did have ER/PR, but I think your point is well taken that sometimes over time, the tumors can change and they can lose the expression. And in that case, I wouldn't expect sort of an anti-estrogen approach to be effective, but instead would want to go with something that might be a more standard approach, or a non-hormonal approach, I'll call it.
Oh, we have another one. Based on this information, is there any reason someone with ER and PR negative tumors currently in NED status should avoid using any form of estrogen?
I don't think so. It's a really good question. I don't think so. I don't think so. I'm cautious about estrogen replacement personally, but that's just because this is what I do. But I think on a case-by-case basis, for sure. I have a lot of women that use estrogen in various forms for management of menopausal symptoms, and it can be super helpful. And I think particularly if the tumor was very confidently ER/PR negative.
Okay, is there any significant differences between the three aromatase inhibitors?
Yeah, so anastrozole and letrozole are structurally more similar. Exemestane is a bit different. And that's why I think Caroline's story is a story that happens in breast cancer also. Whereas if you're on either an anastrozole or letrozole, which are very similar to each other, and progress, then the next sort of line can be exemestane, because it just interacts with the estrogen receptor structure a little bit differently.
Okay. I have a question. Have you used Megace at all? We've had one or two examples of women who used Megace, and it seemed to work just like the aromatase inhibitors.
Yeah,
which
so
is progesterone, right?
Yeah, yep. So Megace is a progesterone sort of based approach. I personally don't use it, not because it doesn't work, but because it can be very, very hard to tolerate, and it can be difficult to stay on for a long time because it's not very selective. So you can have other endocrine effects from being on it for a long time. So way back in the day, Megace was used very, very regularly. But then as sort of the anti-estrogen field has evolved, tamoxifen, and then into aromatase inhibitors, most of the time people are in the newer estrogen suppressing agents. They're just better tolerated.
Okay. What about the use of local estrogen for menopause symptoms? if you're already on letrozole.
Yeah, so I would say that's something I would talk to your local team about. Yes. And so, yes, patients do use topical estrogens for symptoms, but it really depends on, that's something that I work closely with the gynecologists on. I want to make sure someone doesn't have a pelvic recurrence. Like, do they have a vaginal recurrence? Where is their disease? How much systemic therapy, how much systemic absorption do we think whatever preparation they're getting is going to be meaningful? So I work with the GYN people closely if that's recommended.
Other
Yeah.
questions?
The progesterone drug, it's Megace, it's MGACE.
Oh, that's what they wanted to know. Okay. What about some of the, excuse me, what about some of the side effects of the aromatase inhibitors? Some women profusely complain of joint and bone pain. Not everybody, but I know that's well documented in the breast cancer field.
Yeah, no, definitely. The aromatase inhibitors, because they're further estrogen suppressing, are going to have a side effect profile that's very consistent with sort of a more of a menopausal state. So people will get hot flashes. People can get, just like you said, Sharon, one of the main side effects that people feel is joint pain. Interestingly, for some women, the strategy to try to help manage that is to be more active. So exercise can be really, really helpful. The other thing that can help is if despite exercise and trying to increase mobility, people are still having pretty debilitating or bothersome problems with their joints. Sometimes changing between one brand and another can make a difference. So going from letrozole to an anastrozol's other name is Arimidex, that can make a difference. Switching down to exemestane, that can make a difference. So sometimes just rotating through can be, the side effects aren't always the same. And then for some people, it just becomes life. It just can't be, they just can't tolerate it. And in that case, just, if you're rotating through and it's still not better, then I might switch to a different approach like fulvestrant or, like a different estrogen lowering approach.
Thank you. Other questions? Do we know what percentage of women with, it would take a bigger study, but what percentage of women who express estrogen receptors, positive receptors, what percentage actually respond to aromatase inhibitors? Do we know that at all?
I don't think we know that. That's a really good question. I don't think we know that.
Okay. Would you consider this as a third treatment over trying another chemo?
I think it really depends. It depends on the individual's situation. And for me, it depends on the degree of expression in the individual situation. So if someone has high ERPR and you feel confident that the expression is accurate to the current disease. So what do I mean by that? If somebody has high ERPR, let's say on their original tumor, they develop metastatic disease. They've been through multiple lines of chemotherapy. The tumor's progressing. Would I consider an aromatase inhibitor in that situation? Maybe, maybe not. It really depends on, it would be great if there was new tissue that confirmed that there was still estrogen and progesterone receptor, so that if we were going to try it, that we had that confidence. If they had never had an estrogen, an ERPR, an estrogen receptor, an aromatase inhibitor blockade, their tumors were progressing, and they wanted to try, as long as we had a short interval follow-up, then it could be considered. And the reason that I say that is if we go back to that very first paper that I showed where people had ER/PR expression, but unless you were very high expressor, the average time to progression was 3 months. I just like to be I try to be very cautious, because if it's not going to be the right fit, then we want to know soon so we can pivot to something else.
Right, right. I've had people ask me if they could take an aromatase inhibitor with their chemo.
Yeah, that's a really good question. So it's interesting because in the breast cancer literature, they typically don't. It's either one or the other. And I don't think it's ever been looked at it's certain, not that I'm aware of, has this ever been looked at in leiomyosarcoma. I can say completely anecdotally, like, I've had patients that have chosen to stay on, even maybe after I told them to please stop. So, and the rationale, like the thought is that I've talked to my breast cancer colleagues about this, and the thought was always that if there are cells that are ER/PR sensitive and you basically sort of shut them off, and then you're using chemo to try to like inhibit, like kill the dividing cells, but you just shut them off, then maybe it wouldn't work as well. I mean, that is not a very medically sophisticated answer, but that was sort of what we used to say back in the day. To me, what matters the most is that there's good communication with your doctor, and that you have a shared plan moving forward. I don't think that there's concerns about toxicity. And as I said, I've certainly had people who have opted to be on both.
Yeah, I wouldn't think they were counterindicated other than knowing which one is working and which one isn't.
Yeah.
Yeah.
I would not start them at the same time for exactly what you said, Sharon. I would not start them at the same time. The cases where I've had where people have opted to stay on is if they have been on an aromatase inhibitor for a long time, and then there's progression and we decide to start chemo and then they never stopped or something like that. It wasn't always intentional. But I agree with you. I would not start them concurrently, because then you can't figure out what's what. And then as you start to have side effects, it gets hard to peel back.
Yeah. Okay. A few more questions in the chat box. And I can't pronounce this. How does
fulvestrant. So fulvestrant works. How does fulvestrant work? Fulvestrant works. It works by interacting. Let me see. How can I explain it better? So tamoxifen works at the estrogen receptor level. Aromatase inhibitors work by stopping estrogen production. Fulvestrant works again more at the receptor level, but structurally, it works at the interaction point between estrogen and the receptor. I apologize that I don't have a better answer for you at this moment. For those of you that don't know, fulvestrant is a depot injection, so it's not an oral therapy. It works by it's an intramuscular injection that works over time.
Okay. Sue wants to know, if one stops an aromatase inhibitor after a long time and there is growth or recurrence, is there any way to know if going back on that aromatase inhibitor would then treat this successfully?
Yeah, I think that I would think about it similarly to the way I think about other medications and drugs in that same scenario. So if you stop a drug, but you've never progressed on it, particularly if you, like, let's say you go on a hiatus, like you just take a medication holiday. So you've been on an aromatase inhibitor, you take a medication holiday, the tumors start to wake up and they previously had responded. I think it's perfectly reasonable to try again. Whether it will work or not, you never know until you try. But in that scenario, most of the time when we re-challenge, there usually there's benefit if there had never been resistance. If there were multiple additional treatments in the middle, because we know tumors can get more differentiated, I'm not sorry, they can get more dedifferentiated and they can lose their ER and PR. I might still try it, but again, with sort of close follow-up just in case.
Okay. Can ER, PR expression change over time with recurrences?
Yes. Yes, and it's the way that it changes is typically by being lost. It usually goes down. It doesn't usually go up.
Well, Caroline, I don't like this question. How much do fat cells contribute to estrogen production?
So we know that fat cells make estrogen. You know, I think that, and that's why drugs like aromatase inhibitors work sort of again on this peripheral non-ovarian production of estrogen. It's generally a good idea just to try to, it's the same thing for breast cancer where people advocate for just good healthy lifestyles and maintenance of wellness and general healthiness.
Well, isn't there a association of being overweight and breast cancer, thinking that it is the role of estrogen that might play a role in that?
Yeah, yes.
Okay. Other questions? All right, no more? Well, if we have some questions, can I email you?
Of course.
Okay,
Absolutely.
and then I could get back to the Facebook group.
Okay.
Well, thank you very much. Can we give her a virtual applause here?
Oh.
Good to see you, Dr. George.
Nice to see you too, Paula. Thank you for coming.
Yeah, thank you so much. And we'll have this recording on our website. So thank you so much.
All right. Thanks, everybody. Good night.
All right.
Bye-bye.
Bye-bye.